Welcome everyone to the American Institute of Physical Therapy. This is Karthik Yadagiri, your physical therapy doctor. This is just a continuation of the treatment video series. Here we're going to talk about knee today. There's some of the techniques which are required which you did in the ankle. So if I refer back, please refer to the ankle one first. If any problem you see at the knee, it could be an anterior, medial, lateral knee pain. The patient could come with osteoarthritis diagnosis. They could come with meniscal injuries. They could come with instability to the point that just not complete tear of the ligament, but they have some instability issues. They have trouble going up and down stairs. They have pain at night, trouble sitting, squatting, getting out of the chair. So if the pain is at the knee, don't forget regional interdependence. You have to rule in or rule out the hip and the ankle before you treat the knee. I'm going to focus on the techniques that can use at the knee that will be beneficial. So 2 mobilization or manipulation techniques. One of them, ask the patient to lay on their back. Ask them if they feel better if you do a glide posteriorly or anteriorly. They might feel better in one of the directions or might not. The other thing I want to show you is the rotational. This is where most of the patients have trouble with, either internal or external, typically external. This technique involves where the left hand or the non-performing hand to stabilize at the ankle joint, which is just proximal to the knee joint, and you use your distal hand to hold the ankle and do a rotational when you are moving. So you want to do that motion coming down. This is usually helpful for loose bodies, meniscal injuries, or rotational instability. The other one where trouble has is the patients typically pain in the lateral part of the knee, have difficulty moving their fibular head. It's very stiff. And I want you to do this technique after you perform the J stroke, which was mentioned in the ankle video. So this technique involves where you use the non-performing hand at the head of the fibula. Hold on to it and push it posteriorly, and where the patient actively dorsiflexes the ankle. So I'm going to push back, pull your foot up and down. You'll do that at least 3 to 5 times. Before, sometimes you might hear a click or a pop, but if you don't hear it, that's fine. Don't do it more than 5 to 8 times. So push back and ask them to dorsiflex and bring it down. Push back and dorsiflex. This is one of the techniques the evidence shows or suggests that's going to be helpful for pain on the lateral knee. The other thing you want to focus on patellar mobility. If they're not able to move, I don't want you to just move it. I want you to go to the end range, kind of oscillate in the direction they're not moving. But now we know from research, it's not the patella that's the problem, it's the rotation of the hip or the internal rotation of the femur that's mostly dysfunctional. So don't worry if this doesn't move too much. If it feels really different from the other side, that's when you want to try this technique. So the other methods or options, IHDM is a great option if you have knee pain. You want to focus on this area. This is the area where things don't move out. As you can see, I'm almost perpendicular or just about 80 degrees. The pressure is going in or away. It's a thicker tissue, so you want to use a lot of pressure. But be very careful with the medial aspect of the hip because it's very sensitive. You don't want to put a lot of pressure. So you want to start gentle with less pressure and then let it go. You can also do this passively first and then progress to movement. Ask them to bend if they have trouble, and you continue with your strokes. Bend at your knee and straighten it out. So you can ask the patient to continuously do the motion while doing the technique with the tools. You can do this posteriorly on the hamstrings and the glutes for the same effect. You could also use cups and have the same effect. You could do it medially to desensitize the area. I typically put in different angles so it covers a lot of connective tissue, and ask them to bend their knee if they have trouble. So as you can see, the cups are going to pull the tissue and they have good way to resist. They might feel pressure sometimes. Are you feeling okay?
Yeah.
So you want to do it passively or actively. That's one treatment option that you could do for problems with knee. Go ahead and lay on your stomach. So you can do the same techniques with a larger tool on the knee. As I said, you can go all the way to the glutes and hamstrings to cover a larger area. But remember, there's a lot of pressure with it. You want to cover, including the gastrocs and soleus too, if you want to. But as you can see, the pressure is a little bit more in this area. You want to support them so that way they don't feel uncomfortable. You want to finish that technique. That's one of the options. And the other option is the exercise, the most important option. So if you can step off the table, we'll go and show you. One way is the suspension, where people feel they have trouble going down onto the floor. So the best way is to use suspension foam. I can use a larger band to suspend them, and I ask them to squat down to the point they're comfortable or having trouble with range of motion. So they can go up and down. I gradually bring them closer to the anchor point, so that way they feel like they're able to go down without leaning onto it. Just go down, but don't support yourself. Yes, come back up. So that's one option if they're having trouble squatting. The next one is self-mobilization, sitting at a table or a chair. They're going to hold their knee tight because rotational mobility is a problem. Remember, assessment is the key. These are some options and tricks and techniques. You ask them to rotate at the knee because the foot stays down, the heel stays down, and they rotate their foot in and out. So that improves the rotational mobility of the knee. That is usually the key problem patients tend to have when they have knee pain, and also sometimes a groin pain. So that's one of the options you can use. And exercise-wise, the greatest one, if you want to see what helps them if they have trouble anterior posterior mobility of the tibia. So you can use a mobilization belt. So if they feel better, if they're supported this way, they can squat with the pull being posterior. But if you have identified the opposite, ask them to turn around. And no slack. They're going to lean back and the pressure is pulling forward. So this is mobilization with movement as a treatment option. Based on your assessment, what do they feel better with? You can also do it with medial and lateral pressure. So if she's facing me, point yes. So you feel the pressure pulling that way and she's still squatting down. So the pressure is pulling that way. And you can do it multi-directional based on what's comfortable and what alleviates their symptoms. And the next progression is you want hip stability or rotational strength. If you don't know how to use these bands, don't worry. If you're confused with this, don't worry. We can make more videos so you can educate. I want to show you different options that we typically use. So as you can see, if the right knee was the problem, I'm working on rotational stability at the hip without just turning. That resistance or the anchor point is far away, and she's using her hips in a controlled fashion, improving her rotational stability, because most of the time now we know the problem is lack of control of internal rotation or external rotation at the hip that leads to knee pain. So that concludes your options with strokes, manipulation, IHDM, cupping, and the exercises and suspension form of treatment for your knee. If you have any questions or comments, please post them down and we'll get back to you as soon as possible. Have a great day.